Professor Horby, thank you for joining us on G&T this morning.
Yes, pleasure.
So the big unlock happens tomorrow. Will you be having a pint tomorrow afternoon?
I might not rush straight into it, but I certainly will be planning one or two at some point. I think many people are looking forward to doing many things that they've, not been able to, and have very much complied with the rules, which is great. And it's meant that we're at a stage now where we can start to relax things.
So shops also reopen tomorrow, non-essential retail and pubs and restaurants. You can eat outside out again. Case numbers going right down, hospitalizations going down. How comfortable can everyone feel now about being able to enjoy shopping or getting back together again?
I think the watchword has got to be caution, really. The modelling, which is now pretty good, does show that we can expect some kind of rebound, and that it's not clear exactly when or how big it will be, but there is, I think, inevitably going to be a bit of a rebound in the number of cases when things are relaxed. It hopefully won't translate too much into hospitalizations and deaths because of the vaccine program, but there will be some of that. Now, the extent of it really depends on how well we comply with the ongoing restrictions. So we really have to take this step by step.
Well, let me just ask you about that, because what is it now? 60% or something of all UK adults have now been vaccinated, the fastest rollout in Europe. And as we've discussed, deaths, hospitalizations and cases right down, yet still you appear to be sharing the government's quite cautious approach to this. Why is now not a time for us to be joyful and happy and enjoy the freedoms we're getting back?
Well, I think we can be joyful and enjoy the freedoms, but we've still got to realise that there's still a large number of people who've not been infected or vaccinated, and so they will be at risk. The virus is still present in the community, so we will see infections. And even though the risks are lower, there are still some risks of hospitalisation and deaths, even in the younger age groups. And we have to remember that not everyone in the risk groups is vaccinated, and the vaccines are very good, but they're not 100%. So there will be some people vaccinated who won't get adequate protection. So there is still a risk there, and that's why we have to take it cautiously.
In the government's roadmap, obviously, step 2 begins tomorrow, Monday, then step 3 mid-May, and step 4 mid-June, June the 22nd. The government has given hope, strong hope, of an end to all legal restrictions on our behaviour and movement by June the 21st. How likely do you think that is from where we are now on April the 11th? And do you think that hope is deliverable?
I would not want to commit, to be honest. What we have seen, data came out very recently showing that the case numbers are now sort of plateauing rather than dropping. So we're still seeing transmission, and as we open up more and more, we will see more and more transmission. And I think the phased approach, saying that each step will be decided by looking at the data, is really the right thing to do. And I wouldn't want to prejudge that. I think we have to see how things go after the openings tomorrow and then the subsequent openings later in May before we really decide that we can go back entirely to normal. We really don't want to see any more restrictions on people, and it may be that we're better off accepting a mild degree of restrictions rather than letting it all hang out and then having to go back to a lockdown.
And legal restrictions as well, of course, because there's a difference between health guidance, which some of the rules that we've been living under for most of the last 12 months have been, and legally enforceable. But you would still see potentially a need to have legally enforceable restrictions going on past June the 21st into the summer.
Whether they're legal or not, I think is more a matter of debate. But I think there is going to be a need for continuing some of the measures that we know are not very restrictive, but do have a benefit, like hand washing, potentially ensuring good ventilation in indoor spaces, not having overcrowded indoor spaces with poor ventilation and poor lighting, etc. Things like that. And we'll have to see mass gatherings and how we deal with those. There may be in some settings, such as large events indoors, may be a risk that we're not willing to take without some additional measures like prior testing.
That would include obviously just not nightclubs, but maybe concerts, theatres, even cinemas, potential crowded cinemas only?
Hopefully not, but I think we have to again see what happens with the data, and if we are seeing that transmission is occurring in those settings and it's putting at risk, the rest of the population, then measures might be needed there.
When you say you look at the data, and this is the great mystery, I suppose, for the unscientifically educated, like most of us, certainly me. Say, let's look at the data, and the government is saying the same thing. Let's take this, 5 weeks at a time, and give enough time to look at the analysis coming through, cases rising. We all expect cases to rise, potentially hospitalizations to rise a tiny bit as well as the caseload goes up. But how much can they rise by without us having to worry, about new restrictions? What is the danger mark now that so many people who have been at risk have been vaccinated, everyone over the age of 50 or so nigh on?
I think there's two main risks. One is the individual risk to those people, and how much illness and death we as a society see as acceptable. We do see deaths every year from pneumonias and influenza and many other infections, and so we won't get down to zero for COVID, I don't think. But we have to decide, as a society, as to what level we're willing to accept. And the other dynamic is the health service. The health service has been under enormous pressure. We want to get back to delivering the normal service within the NHS, and we don't want to put additional pressure on the NHS. Now, the scenarios that have been looked at would suggest that it's very unlikely that we'll get back to a situation where the NHS will be under extreme pressure. But we really need to make sure we do avoid that at all costs.
And that sort of terrible scenario, I think that SAGE had looked at some modelling from the SPIAM committee, had predicted last week as a very worst case scenario. Yes. That would only be the case, as in the NHS being put under severe pressure again, that would only be the case if presumably caseloads went far, far higher than they have been at the peak of the previous 2 or 3 waves, depending on how much you're counting, because so many more people at risk will no longer be at risk, presumably.
Yeah, you're right. It is the most pessimistic of all the scenarios looked at, and it's done for planning purposes. What do we think is the worst case? And the worst case is that if after June, the relaxation of measures, we go back to the very high levels of transmission that we saw when the pandemic first came, and we sort of take some assumptions about the numbers of people who aren't fully protected by vaccines, etc., and make those sort of at the worst end of assumptions, then you might see significant pressures on the NHS. But it's important to stress that is the worst case scenario, and we would hope to avoid that. But that's what we'll be looking out for very carefully over the coming months to make sure that we're not headed in that direction.
I suppose your point about how many deaths, how many hospitalizations are we prepared to live with as a society when we start to open up, when transmission increases again naturally, that's a political decision, isn't it? I suppose that's one for all of us to have a bit of a debate about, because there will be deaths. Do we live with 50 deaths a day? Do we live with 20 deaths a day? Do we live with 100 deaths a day? I mean, do you have a view on that?
I agree that it's a political decision. It's a social and political decision. And the science can't give you an answer to that. It can give you an answer as to what's the range of numbers that you might see, and it can give you comparative data as to what we would have seen over the past 15, 20 years with influenza, etc. But then it comes down to political decisions as to what's acceptable. And we've seen extremes on both sides of that sort of gradient, where people are saying we should have zero COVID, and other people saying that the medicine's worse than the disease, and that we should just accept a higher range of deaths than we have seen.
Probably it's a really difficult thing for the government to say, isn't it? For any minister, or indeed prime minister, to stand up and say, I've decided that we're going to accept 20 deaths a day now. I'm sorry about you 20 people who've died from this, but that's the price that we're all going to have to pay to open up. But that is the realistic scenario and equation that's going on now.
Yeah, I'm afraid there are some very ugly equations that are underlie all this. I mean, not saying we actually have looked at that, but it is a question of this is the number of deaths you would expect if you took these measures or didn't take these measures. And there's also the cost effectiveness. How much are you willing to pay to save a life? And those sort of decisions do go on all the time within the healthcare setting. But they're very unpalatable, but unfortunate truths, really.
couple of practical issues I don't know if you have a view on. School children have been asked to wear masks going forward through the summer term now, certainly at the start of it when they go back. We thought that would end with the end of the Easter term, school children over age 11, of course. How long, in your view, do you think children should be wearing masks in classrooms for?
For me, the question is how effective are masks in that setting, in terms of compliance amongst children of wearing the masks, and compliance with other measures, etc. And I do think that is one area where we haven't really got the evidence that we would have liked. It would have been great to see much more work done on evaluating the impact of mask use in different settings over the past year, which unfortunately we haven't got. So I think there tends to be a sort of precautionary approach, which is that, you know, they're widespread, they're cheap, they don't have any harms, and so they are worth using, not least because they give people an awareness that there is a risk.
Why have you been unable to get that sort of data on mask wearing? We've all been doing it for quite a long time now.
Yeah, it's a very challenging sort of study to do, and actually there has been studies in the past of mask use, most of them looking at sort of different types of masks in hospital settings, but there have been some studies of mask use in the community. Generally, they've shown a benefit, but a very modest benefit. But it's very difficult to disentangle other sort of factors as to, you know, whether people are washing their hands frequently, what the level of compliance with the mask use is, to really understand how useful they are. And again, we've seen sort of polarized discussions where if you look at the sort of the biomechanics of capturing droplets in masks, then you would argue that they're very effective. But then if you look at the real world trial data, you would say they're less effective. And the situation really has been, well, we're in the middle of a public health emergency. Perhaps we should just recommend widespread use of masks because we don't anticipate any harm. And even if the benefit is modest, it's worth having.
Let me ask you a little bit about variants, new variants. Obviously, as chair of Nervtag, one of your major responsibilities is to monitor new variants when they emerge. And so far, the numbers would tell us that we've kept the spread of new variants or variants of concern, as you categorize them, as very well down during lockdown. But of course, the lockdown itself, people not moving around, has had a lot to do with that. So when we move into step 2, then step 3, and then step 4, how much of our increased movement and socializing again is going to increase your concern that the spread of new variants is going to increase?
There are two caveats to the modelling that's been done that underlies a lot of the decisions about relaxing the measures. One of which is that we don't get a new variant. That means that people can be easily reinfected and get very sick. And the other dynamic is that we assume that the vaccine efficacy, effectiveness against infection and disease remains the same. Now, if either of those two things change and they in some way are linked, then all bets may be off, to be honest. So we're watching them very carefully. At the moment, it's been very reassuring. We have not seen extensive spread of some of the other variants that are worrying, but they have spread in other countries, and we've seen in some European countries spread of Brazilian variants, etc. So we want to monitor it very carefully. We'll be in a better situation now because we have lower prevalence of infection. It means it will be easier. The system will be able to cope easier with testing, tracing, sequencing of clusters of variants of concern. So we'll be in a better position to get a handle on them and get control of them quickly. We do have to be cautious about reintroduction of these viruses. As we saw in 2020, we had quite widespread introduction of the virus from various European countries, and what we don't want is to see widespread reintroduction of these more worrying viruses. So I think that's why there is going to remain quite a focus on international travel and controls at borders, etc.
Let me just ask you about the variants that we currently know about. Obviously, South Africa, but there's our own Kent one, I suppose we know all about. But there's the South Africa one and the 2 Brazilian ones, one which is a lot more concerning. The vaccines that we currently have, all of them, the 3 currently being deployed, all have some, if not quite a lot of protection for all those 3 current variants of the concern, do they not, to reassure people?
Yeah, I think we can be reassured to an extent. What we can measure in the lab is that, against the Kent variant, the vaccines seem to work extremely well, pretty much the same as the previous variants. A little drop, but probably not of any clinical significance. But what we do see in the lab is that for some of the other variants, the Brazilian and South African, is that the drop is bigger. Now, what we don't yet know is how that translates into actual protection, because what we measure in the laboratory is antibodies, etc. But there are other components of the immune system that are much harder to measure. So it may be that the laboratory data is more pessimistic in terms of the level of protection. And so I think at the moment we're fairly confident that there will be a reasonable level of protection, but until we actually see a significant number of vaccinated people exposed to these viruses, it really won't be clear.
The real life results with people getting vaccinated. Yeah. Let me ask about the Nigerian variant. This one has cropped up in the last week, certainly in terms of hitting the public consciousness. Is that one that's concerning you? How infectious is that, and what's vaccine efficacy for the Nigerian variant?
I actually haven't got the data on that variant at the moment, so I'm not able to answer that question.
Fair enough. Let's talk about vaccine passports then, because there's been a huge amount of debate about COVID certification, as the government calls it, domestically and for international travel. Domestically first, how useful are COVID certificates to control the battle against new variants spreading in the UK?
So certification is not straightforward. There's various ways you could certify somebody as being sort of themselves not an infectious risk. One is vaccination, which again requires that there is a good process for certifying whether someone's been vaccinated, and there's not any gaming of the system or fraudulent documentation. The other way is demonstrating you've been infected. Again, that's not straightforward because it depends on which test has been used to demonstrate infection. The so-called PCR test is very good, but some of what they call the lateral flow devices, the things that people are using at home, are good for screening, but they have a higher rate of false positives and false negatives, so may not be quite as reliable. And then you have all the social and ethical issues that we've heard a lot about in the press about to what extent these kind of measures would actually be discriminatory and lead to two-tier societies. So my personal view is that they do have a value, but it's probably quite restricted, and actually that their use in terms of international travel may be one of the use cases, as we call it, that's most justifiable, because what we really do want to do is to avoid importation of new higher risk variants.
Yeah, and that's obviously a very powerful reason the government have explained so far why they want to keep international travel limited. May the 17th is obviously the big date where we may expect to change that, or we may not. What is your advice to people who might be listening now, who really do want to go on a summer holiday, who wouldn't, when they're thinking about booking one? Have you booked one yourself, or would you advise people just to hold off for the rest of this year?
I vacillate a bit, to be honest. I would really like a holiday. I haven't had one since 2019. But I think that at the moment, I've not booked a holiday overseas, because I think that, number one, there's a risk that whatever I book won't turn out to be feasible. Number two is I don't want to get stuck overseas somewhere or have to quarantine for 2 weeks when I come back when the situation changes. The situation in the UK is becoming clearer and is stabilizing, but people have to remember that that's not the case elsewhere. The pandemic is still raging globally, and many countries in Europe even are still seeing very significant case numbers that are having to reintroduce lockdowns. So it's very hard to predict what will happen in the next couple of months, and so people have to really take that on board, that any plans they make now, they have to understand that they are at substantial risk of having to change them.
So it would sound like don't book anything for a few months yet.
That's what I'm doing.
Okay, you can't advise everyone else on their travel plans. I accept. We'll leave that one to the Prime Minister in a few weeks' time. Do you have a view, though, on whether lateral flow tests should be enough to allow you to re-enter the country after your foreign holiday. It's a big debate, isn't there, whether you should have a PCR test, a more thorough test, or whether a simple lateral flow test should be able to get you back into the country, because of course the difference in price is huge. A family going on holiday for coming back could spend over £1,000 having to pay for PCR tests when lateral flow tests are free.
Yeah, these sort of questions come down to sort of trade-offs between the sensitivity and specificity of the test, how good the test is, and how many false positives and false negatives you get, versus the practicalities of doing it and the costs of doing it. The lateral flow devices, if done properly, are reasonably good. With either of the systems, you will get some false positives and false negatives, but I think we have to accept that there will be some people slipping through the net, but I think we can tolerate that.
With lateral flow tests instead of PCRs, that's a tolerable risk to have, is it?
Well, I think it probably is, yes.
Finally, let me ask you about long COVID. You've been doing quite a bit of work, as others academics have been, on long COVID over the last year, but especially quite recently. One finding of a major study you're involved in was that younger working age women are most likely to suffer from long COVID after they've experienced hospitalization for the disease. Why is that?
I wish I had an answer, and that's what we need to find out. COVID is a new disease to all of us. We've learned quite a lot about the hospitalization natural history of disease. There's still a lot more to learn. We still don't have enough good treatments, and we still don't understand all of the pathology behind severe disease. And we understand even less about long COVID, including who's at risk of developing that or why. There's a very interesting gender difference throughout the whole spectrum of COVID, where men are much more likely to get severe disease and die from COVID than women, and we really don't even understand that either. So it could be a true gender related issue. It could be related to the fact that the men are getting more severe disease and are dying, as opposed to the women are not, and are then living with longer term consequences. So I think what that tells us is that a lot of research is needed, and I think that is being invested in, which is great.
Sounds like a few more years' work left in COVID for you then, Professor.
Yes, I think for all of us. Something we're going to have to live with for a bit longer, I'm afraid.
Professor Horby, thank you so much for joining us this morning.
Thank you very much.